thanks everybody for joining us in this digital format today for this session. If you don't know me, and loads of people won't, I've just seen the variety of people joining from different sectors, backgrounds and regions, so it's great to have you all here. I'm Stuart Cowley, I'm Director for Adult Social Care and Health at Wigan Council, and also Chair of the Northwest ADAS branch, part of this this partnership today, putting on this event and others to come. So really great to have you with us. I'm not an expert on Zoom, and many of you may be, but I think my first job is to pass to Nathaniel, who's going to take us through a little bit of Zoom etiquette before we get into the intro proper. So Nathaniel, thank you.
Good morning, everyone. I'm Nathaniel. I'm from Northwest Employers. I'm a support officer. I'm just going to talk you through a bit of the Zoom etiquette, just so we can have an easy run today. Okay, so we will just make sure that all of our mics are muted when the speaker is talking, just so there's no interrupting. You can change the participant name and show your name, change your name or surname by clicking on participant at the bottom of the screen. If just the two people, like the two bodies stood next to each other. If you have any questions, please just type them in the chat box and we'll try to answer all the questions that you have. We may not be able to answer every single question, but we will follow up with an FAQ after the session if you do have any other questions. If you click on the reaction box, which is the smiley face with the plus sign on it, you'll be able to put your hand up. And the mute button is just the microphone at the bottom left. Try to keep your webcams on, but if you don't want to, that's completely your choice. Handing back over.
Thanks, Nathaniel. I feel partly trained up now, so that's dead helpful. Just a little bit about this partnership, I suppose. In ADAS, you can see us in the kind of burgundy circle there, but a thank you in advance, I think, to all of the people who've been involved in these things. Take some organising and bringing together. I know we're just at the outset of our discussion today, but I think a few years ago, the organisations listed realised we had some really similar interests, and everybody was interested in improvement and learning in public services across care, across the NHS and the wider public sector, across local government. And sometimes I think we were even competing for space. And I think we've had the fruition of a few years now of a really strong partnership in planning events that hopefully are of interest right across kind of public services, but are meaningful to residents receiving services too. So this is kind of the latest of our sessions that we plan together across that range of organisations. To thanks again to everybody involved. I think there'll be a plug for future events at the end of this one, probably, but look out for them. And certainly from an ADAS point of view, it's been a great partnership to be involved in. So thank you. We put a lot in, but we get a lot out. Just moving on to our day today. So we've got some fantastic inputs, and again, thanks in advance to our kind of main speakers today. I am going to do a little bit of an intro here or after the program slide, just a few thoughts from me, but we're going to get quite quickly taking a straw poll from you on your basic thoughts about the care agenda and what's important to people in their real lives, into some inputs from Madeline and from Neil that are going to follow on one from the other. Madeline's the author of Labours of Love, The Crisis of Care, and Neil is part of Social Care Futures, and I think we'll let the inputs kind of speak for themselves, and then be able to have a bit of a question and answer session from what Madeline and Neil kind of provoke our thought waves with, and try and kind of coordinate some questions through the chat in the right way for Madeline and Neil to respond to. Then we've got our own Charlotte Walton giving a kind of case study from the Northwest Patch, which is the Cheshire West and Chester journey, on kind of placing adult social care in the right place in that system. And then the chance to respond to all of the feedback we've heard from the three speakers and discuss things in a bit more depth in our groups, which we're going to get, I think, some flash feedback from on the day, but we're going to promise you that we're going to capture that learning and feed it into our own work in the branch. So that'll take us through to midday. So hopefully that feels like a good agenda for you, and we'll get to it soon. Next slide. Oh no, before that, I think, or just a couple of thoughts from me to kick it off, I suppose. You know, reframing adult social care. And so I've been a director for like 10 years in this council, in Wigan Council, on adult social care, and worked on adult social care for about 20 years or so. And so I've got a longish memory in my own right, I suppose. And I saw Dillis in the chat. I haven't got a memory as long as that, but was talking about this being an auspicious day to run the event because of, you know, previous kind of heroines standing up for what they believed in and the connection to the agenda today. So yeah, my mind doesn't go back that far, but I think, you know, perhaps some of the inputs we're going to get are around the centrality of social care when it touches people's lives. And I suppose I remember, like, if I was going to today, I'd be thinking about perhaps the tendency from the current government would be to say, we've put a tax, we've raised some money through national insurance, and we put a cap on the personal contributions that some individuals will pay for social care, therefore it's fixed. And I don't think that's quite how we'd probably feel here. And in fact, in kicking off What's Care 2030, which is the regional kind of vision for the branch for social care, just pre the pandemic, early 2020, I think we were thinking that central government had been like promising in a range of you know, different political leadership configurations over many years for adult social care reform, but we weren't seeing anything particularly meaningful around how people live their lives. And we kind of captured new care models that are person-centered in the first place, with social contact at the core, with kind of citizen and family empowerment at the core. And then the issue around kind of workforce and viable services being really tricky to kind of sort out. And I think we've got a framework for working on that for the next few years that is going to keep us really busy. But going back to, I think, probably the most interesting bit of central policy I can remember would be putting people first, which was actually going back to 2006 and was at least the attempt to push personalisation to the front of the agenda for social care. And I think came from a kind of user-driven movement around put me at the centre, don't assess me for my deficits and give me some kind of limited menu of options to meet my need and be lawful, but actually put me, my wishes, my passions, my best week at the centre, and allow me that choice and control to create my best life. And I think that was probably the most interesting bit of policy that I think probably social care is still further on with than the NHS. I think the sense of perhaps the public, I know we've got lots of NHS colleagues in today, and we love you all. And the sense of the kind of sacrosanctity of the NHS, the absolute kind of pride in the NHS. I think perhaps the profile of social care is actually higher in the public consciousness because of the pandemic, perhaps, and the fact that social care is so important when it touches you or your family's lives. But there's probably still some work to do in that parity of esteem around social care and the NHS, and understanding each other better, which might come through in the session. But also the sense of, you know, social care, the incredible work you can do in that sector. Paying conditions for people working in that sector, the economic value that social care can bring as part of a kind of, you know, repositioning the economy of the country. There are really sort of interesting ways I think we can look at that reframing of social care, and those are things I think we're wrestling with in the region, and I'm sure will come through in probably more kind of hard-hitting and authentic ways from the inputs of Madeline, Neil and Charlotte. So those are a few thoughts from me in kicking off the session. if we can now go on to the next slide, I'm going to ask Helen to now come in, who is practicing for a similar Slido event we've got in another session tomorrow. Helen, so over to you.
Thanks, Stuart. Thanks so much. So I'm really hoping that people have got some smartphones with them. And I think we've got a QR code because we're going to do some Slido polling. So I imagine there's a mixture of people on the call. Some people will have done Slido before, some not. So we're hoping we're going to take you through this in slowly so you can actually get the actual Slido poll. So I think we've got a QR code that people can go to.
Apologies, some tech issues. If you bear with me a few seconds, it will load up now.
Yeah, okay. So I've got it downloaded on my phone, but I think we can, if we've got the QR code, go straight through a browser and onto the actual question. Bear with us. Great. So,
there we go, up and running.
Yeah,
Thank you.
So there's a QR code if people want to scan it. So if you've got a smartphone, generally it's on your actual camera. You can scan it from your camera and it takes you directly to the website. Or if you've got the Slido app, if you want to download it, and if you want to put in that number 507025. That should lead you to the question. And the question is, what words come to mind when you think about home? And we're getting a lot of safe, feeling safe, I think, coming up. Happy, family, safety, family, love, safety, refuge, comfort, privacy, calm, connected, quiet, lots of things coming through. I think we've got 50 people polling so far. I think we've got just over 70 on the call, so we'll just keep it going for a couple more minutes. Safe, safety, family, love, comfort, very strongly coming through. Sunday dinner with family. I really enjoy that too. Warm, safe, relaxed. So I think we've probably got up to about just over 56 respondents there, and very much what's coming through is it's safety, safe haven, family, warm, happy. That's what people are saying. So Stuart, do you want to sort of take over? I think we're going to do something similar at the end. And I think what we want people to think about, but not respond to at the moment, is when we think about care, we're going to be talking at the end about what we think about what we mean by care. So handing back to you, Stuart, that's okay.
Yeah, thanks. I was putting a chuckle in the chat at the number appearing on the 50. It might be the robot assistant at home is called 507025 or something. I was identifying with the garden. I was imagining maybe a glass of wine, which we have got good food, but nobody's gone for a little bit of booze. But
home baking though.
Yeah,
you're a bit into that, aren't you?
Yeah, I like grub as well. Laughter. So yeah, it's not bad, is it? Parties.
Nostalgia. The interesting bits are the ones on the outside, I think. Some of this stuff around nostalgia, homesick, legacy. Somebody's put individual. noisy kids.
Yeah. So as Helen says, we want to kind of revisit this from a kind of a slant based on the discussion today towards the end. So thanks everyone for logging on to Slido app or scanning the camera code and putting your contribution in. That's really great setup. I think without further ado, I know Madeline's on the call with us. I think we've got a request from Madeline to make sure there's some human contact while Madeline's talking to us about her work and the book that she's recently written. So without further ado, I'm going to shut up. And Madeline, thanks again for joining us. Do you want to get us into your input, and we'll make sure you can see some people while you do it? Thank you.
Thanks very much, Stuart. Yeah, I think also the subject lends itself to relationships. So I find it very hard to look at a screen. I need to be able to see that I'm talking to people. So thank you, Stuart, for staying on. Well, it's a great pleasure to be here and talking to you today. And I'm full of respect and even intimidated by the volume and quantity of experience that you all represent, decades of working in a sector which I spent 5 years looking at, but that's nothing compared to what many of you have done. So I offer this with some humility. It's a provocation. It's what an outsider felt after spending 5 years talking to people about care. And I hope it's useful. Certainly the impact of the book has really stunned me and made me think again about what I wrote and why and how. It's an ongoing dialogue, I think. I think the thing about care is that all of us are engaged in this as part of our humanity. And I think separating it out as an industry or as a sector or something I don't need to think about until there's a crisis is part of the problem. Actually, care is something that we all experience from the moment we're born to the moment we die. And this is part of our humanity in offering care and in receiving care. So it's that interaction that is at the heart of my book. Now, controversially, I use the word crisis, and I will defend that. I do think there is a crisis, and I think the crisis is actually more complex and more deep-rooted than is often understood. It's not just about shortages of funding. That is critical, but why is there shortages of funding? Why is it that the NHS is sacrosanct and care is so often relegated as somehow less significant? It's a subject that somehow we've really struggled to engage with, despite the fact that, as I say, it's an essential part of our human experience. So my book started with a very small question, and in a way a very obvious one, which is, what does this small word mean and why is it used in so many different contexts? Inevitably, as a writer, I come to all sorts of issues with an interest in language, with the words we use. I believe they're really important. And again, in the course of my interviews across the country with all sorts of people who worked in care in different ways, it was very clear to me that the role of language, the importance of language. And I know, it was great to start with a word cloud, because that is exactly the point, is getting us thinking about language. We're here today to talk about reframing. And an essential part of reframing is the language we use. So what does care mean, and how do we learn to do it? And I took that small question, that obvious question really, into every single interview I did, hundreds of interviews. And one of the things that I think makes the book a bit unusual is that I didn't discriminate between people whose paid work is care and people who have found themselves through circumstance as spending a lot of their time doing care. I wanted to try and draw common denominators between what is described as informal care and formal care. And I also wanted to look right across different types of jobs which involve care. So I wanted to think about the role that GPs play in care. How do highly educated, well-paid professionals understand the care that they're involved in giving? And then care workers rushing in and out of people's homes, they're 10 minutes here, 10 minutes there. How do they understand what they're doing? And I really tried to have as open a mind as possible at the start of every question, every interview. what can you tell me? And time again, I found it deeply humbling. I've used the word again. I do think care is one of those subjects that, because it brings us so deeply engaged into the heart of some of the most difficult human experiences, that humility is a constant thread really through the issue. But one of the things, I mean, I spent 2 weeks shadowing a GP in a very busy inner city London GP practice, and his description and his colleagues' description of what their care meant and what they thought they were doing a lot of the time was profoundly moving. And in a way, the best way of summing that up would be to talk about witness. They were witnessing suffering and accompanying people on a journey of illness and sickness. But no less humbling was the care worker rushing between appointments, who had found time to sit down with me in a pub to explain what she did and why she did it and how she had come, how she was able to do it. And her description about her family history, which had given her the skills to care. That was a very, very interesting dimension of this, which is that the care workers that I was interviewing so often drew on family history as the inspiration for their work. It was a grandparent or a parent, and they had seen good care, and that enabled them to provide it, and it gave them that empathic bond to think, this could have been my grandmother, this could have been my grandfather, and that's why I want to do a good job. And that brings me to another of the kind of key threads that kept running through this, is that care is inspired and it's learnt by experience. We learn how to care from experiencing care. And in a way, it's kind of obvious, you know, if you look at sort of psychotherapy, therapeutic understandings of care, absolutely wonderfully sort of profound work about the way in which we learn care as very small children, as babies, and it's through touch, it's through a physical memory of care, and that is something that then gets passed on in the way that we parent, and indeed the way we care for others. It's a physical memory, and so I want to get across a point about reciprocity and about how care is inspired, you know, kind of, and it's learnt from by example, and our ability to care is deeply connected to the way in which we have been cared for. And I think those are all big challenges, actually, in policy terms, very, very big challenges, because if there's a sort of big standout issue through the book, is that we don't value care enough in our culture and in our society. And it's people like yourselves that are absolutely on the front line of managing expectations of society on budgets that are not sufficient or adequate. And it seems to me that creates a real crunch in terms of the work that you do about valuing the people that are providing the care in your services. They are not paid enough by and large, and we know this, and we were reminded really starkly during COVID that we expect them to provide care without being able to actually, as a society, ensure that they are being cared for. And that intimate interlinking of the conditions of work and quality of care again and again came up, I think, in many, many different ways. That the care workers I was talking to were honest. They said, I could be getting more money on a till in a supermarket. You know, if I was stacking sandwiches on a shelf, I'd have far less stress, it'd be far less, you know, kind of exhausting, and I'd be paid more. That I did more work last summer for the Joseph Rowntree Foundation in South Wales and various other places. And that was in adult social care. And then again and again, the issue came up around pay. And one of the kind of really painful dimensions to this was that inevitably you recruit people to do care work with a loving heart. That was the kind of, you recruit for empathy, not you individually, I don't want to personalize it, but anyone running a care service is clearly recruiting for kind of empathy. And when I spoke to a private company that provided home care, they said, we go around supermarkets and try and find the really loving, cheerful, friendly kinds of characters. Well, those kinds of people, and often they're women in their 40s or 50s, who've had their own families, often have a lot of care responsibilities of their own. And that's part of what makes them a good carer. They have tremendous emotional skills, emotional intelligence. But the problem about their job is it doesn't enable them to do meet their own care standards, their own expectations of what care should be, either in their private lives or in their work lives. So there is a deep kind of injury, really, often, is that they can't do what they want to do. So if an elderly lady is lonely or frightened after in a home visit, they can't sit down and make sure that she's feeling better after a fall, for example, because they have to go straight on to the next visit. And that was the sort of dilemma that care workers talked to me again and again, of how painful that was to walk out of a home environment where you knew somebody was in a lot of emotional and possibly physical pain. So these were the stories that I was hearing, and it led me to led my research into another dimension, which is to ask the question: why is it that we don't value care better? Why is it that somehow we think it should be poorly paid and it's only work for the low skilled? What is this concept that care is low skill work? Because that was the thing that really brought me up short, is there's nothing low skill about care work at all in any way. GPs understood the complexity and the imagination that's required to care for somebody, just in the same way care workers understood exactly the same things. A good care worker is always being creative about how to protect dignity and respect in these human situations of vulnerability and dependence, because that's what we're dealing with. I think the language around empowerment and self-care and this is valuable, but the emphasis mustn't stray too far in that direction, because I think it's a way of putting responsibility onto people who actually need help. And we need to acknowledge that. That there is a kind of limit to the sort of policy agenda of independent living. That's works up to a point. So I went into a very kind of deep academic research, really, to sort of think about care and there are cultural presumptions around care and around this idea that it's low skill work. Where did these ideas come from? And it was sort of, it was a danger of kind of disappearing down rabbit holes, really, because it was a fascinating body of academic work, which over the last 30, 40 years, a number of very prominent feminist academics across multiple disciplines, philosophy, economics, psychotherapy, history, have developed an understanding of care. So you get philosophy of care, you get the economics of care, and amongst those, and this is international, and many remarkable academics, I think, have really profoundly challenged the Western intellectual tradition. They have argued that the great economists such as Adam Smith, countless others, have completely ignored this vast area of human activity, and that the industrial capitalist system was simply based around a patriarchal model that care would be free or cheap, that it was women's work, and women either did it because they were married or they were mothers and they were expected to do it as their family responsibilities, or it was cheap and they were servants. Millions of servants. I mean, that was a whole dimension of care that I found fascinating and just gets completely overlooked, that it was a major form of female employment up until the 1930s. And much of that was about forms of care. This idea that they were coarse, low paid, long hours, and expected to be utterly flexible. And so there's this kind of cultural distortion is I think so profoundly embedded in our culture, and that is why we continue to think that care should be cheap or free, and that is now producing a crisis, because what has also happened over the last 40, 50 years is an enormous change in the aspiration and expectation of women and their lives and how they're going to spend their lives. And the assumption can no longer be that women will provide large amounts of care for free within the family context. And so, sorry, got distracted by a phone call, care responsibility. So this, so that is one dimension to the crisis, that women are not playing the care role that was traditionally expected of them, either as servants or within the family. And another dimension, I would argue, of the crisis is another long-term trend, which has been the retreat of the welfare state. Because the way that Scandinavian societies, for example, grappled with the question of care was to extend the welfare state. Very high quality childcare and a robust welfare state would take in, would move into the area so that women could then participate in the labour market. And Anglo-Saxon economies like the US and the UK have absolutely not wanted to go down that route. Our childcare system has continued to be an utter disgrace, appallingly so. It's the lowest levels of pay of any care work that I came across. And so we have got our heads very firmly stuck in the sand, that these two dimensions of a kind of century-old system of providing care is fragmenting, and a welfare state is not stepping in. And there are aspects where care and the need for care is increasing. So it's a remarkable achievement of modern science to have extended life expectancy. That is all to be welcomed. But we haven't put a fraction of the same energy and commitment into thinking how those lives are supported through what is typically 6 years of frailty towards the end of someone's life. That's on average 6 years of frailty. And that frailty is very complex to manage, as anybody who has had an elderly parent well knows. The cycle of hospital appointments or visits, the pattern of a slow decline and the slow loss of capacity, and how you manage that. And we haven't really thought enough, or with enough imagination or enough resources, about how that is going to be tackled in the next 20 years, for example, as the demographic challenge of an increasingly elderly population becomes apparent. So to go back to that little question, what is care? I mean, we could, for example, have done a word cloud on care, and it would have been interesting to see what would have come up. One of the things that I do in my book is I sort of punctuate the chapters with a sort of short meditative essay, if you like, on a particular word which is closely associated with care. So I pick words such as kindness. What does kindness mean? Or empathy. Empathy actually is an extraordinarily curious word. It's a very recent invention in about 1912. It comes from a German word. And as most academics would say, actually, it's extremely hard to pin down what it really means. And then I'm curious about the fashions, how words come and words go. Sympathy is a word that people don't like using anymore. Pity is absolutely out. Nobody's allowed to use the word pity. But actually, if you look back through a lot of literature around care, which I did, you know, the way novelists write about care, or the pity plays a very interesting role and is used extensively as a word. So how is it that some words get abandoned, and you can see how there's shifting understandings of this particular human experience of dependence? So I looked a lot at the word dependence as well, and how it's stigmatized, that we live in a culture which places enormous status on independence. And I describe this as really a kind of cruel mythology, because actually we're all deeply interdependent, and recognizing the way that plays out through care. All of us are dependent on the care of all sorts of people for us to have got to your screen this morning. If you just think of some of the ways in which you've been cared for just this morning, and the ways in which you've given care. But at the heart of good quality care, I think, are three words, and those are presence, attention, and touch. And good care is defined by the quality of those three. Now, I'm setting the bar really quite high. Presence is an enormously high bar, but it was really interesting how many people said to me how just the way, for example, in intensive care, a doctor or a nurse opens or shuts the door. You know, your child is absolutely, their life is hanging in the balance, and you can tell the kind of the character by the way they're opening and shutting the door. And attention. Well, a nurse who was running a very, very busy ward, I shadowed her for several days. And she was fascinating, because she said, it's not about the length of time that you spend with people. I'm having to juggle multiple people around this ward. And I could see she didn't sit down for 12 hours. It was an absolute exhausting job. But I could also see how she was capable of engaging with a very present form of attention, sometimes for not very long, quite a short period of time. But in that moment, the person knew they were being listened to. And care is always about rationing attention. You know, I'm not being idealistic here, that people can sit around and, you know, give endless hours. There is always a constraint on resources. So attention always has to be rationed. And you have to make judgments, micro judgments. Who needs my attention now? That's what a nurse is trained to do. But a care worker has to have the same degree of autonomy, it seems to me, because it may well be that they know that one client really needs them and another client doesn't need them so much on that particular day. So attention is very closely linked to judgment and assessing a situation, which requires such a lot of skill. And I think these three characteristics, touch, appropriate, non-sexualized, and meaningful, is because it can be intrusive touch. So touch is again deceptively complex, because it's about your understanding of the person and what they would feel was appropriate and they would respond to. And having seen a carer care for my mother, who was very, very good, I could see how she understood the role of touch. Everybody hates to be patronized by the sort of pat on the arm at an inappropriate moment. But I would say all these three things are they're emotional skills that are subtle. And I think that there's something countercultural about them. That is what I came across again and again in my interviews about care, that many of the values and the practices of care fly straight in the face of what contemporary life is about. That it is, you know, it goes against the grain of our culture in really profound ways. So the more I thought about this, the more I thought that practices of care are a form of resistance to a sort of performance economy, if you like, the kind of the economy of the sort of the selfie, of masses of information, of efficient consumption, the kind of aggrandizing of the self. In all sorts of ways, care is often self-effacing. It's often about stepping out. A palliative care nurse who is immensely sophisticated in her understanding and subtle about, you know, very experienced long-term social worker who worked in palliative care. Many of the times, she said, it's about how I remove myself or facilitate the family's engagement around the person who's dying, and then step out. And I'm there to help hold the situation, but they don't need to even know that. Imagine that. You know, how do you explain that to your boss as part of your key performance indicators? You can see how our modern management culture sits very uncomfortably on issues around presence, attention, touch, and how the creativity which enables somebody to have a sense of dignity in the midst of dependence and sickness. Last year, I was very privileged it felt a privilege to be very closely involved with my aunt's death. And I saw the care workers who came to help her. She was dying of cancer. And I'm just awestruck, really, by how much they were prepared to invest of themselves. This is not a job where it's possible to always hold the boundaries. And that means it's a form of emotional labor, which can be exhausting and can lead to burnout, very easily lead to burnout. And I'm sure many of us are well aware of care workers who've just said, it's too much, I can't cope anymore. Because we are routinely expecting care workers to go into situations which are inherently, can be very painful. Somebody is dying and somebody may be scared and feel lonely. They may feel that you can imagine, I mean, I'm sure all of you know of multiple ways in which care workers are expected to witness forms of suffering that most of us keep at arm's length or only encounter briefly in the course of our lives. So you can see how, given that emotional labor, the cost to self, how confusing it is that we have so undervalued the care system, particularly vis-a-vis the NHS. I think there's a few points that I want to sort of conclude with. In the course of all my different forms of shadowing and observing and interviewing, there was one incident that I found deeply, deeply upsetting. And what had happened was that there was a gentleman dying of MND. He was in the advanced stages of MND, and he had teams of healthcare assistants coming out to help him. And the local community nurse who I was shadowing, a very, very interesting man, had decided that it was necessary to bring all of them together to help describe to them how to cope if there was a choking incident when they were on their shift. And there was probably about 8 people in the room. So that was 8 people going in and out of somebody's house. So they all knew this couple very, very well, had known them now for a couple of years or so. And he described how to cope with a possible end through choking. And I noticed that the people around the room didn't talk to each other. They didn't know each other. They sometimes doubled up, but not always. And several of them began to cry as the nurse was talking, because they had developed great affection for the couple and for the gentleman who I met, who was an absolutely delightful character. And when he came to the end of his sort of description of how to cope, you could have heard a pin drop. There was just complete silence. And then they also pushed back their chairs and left the room. And he turned to me and he said, I just feel so bad, because these are people who have none of the training I have to deal with this. And they don't actually often have colleagues. Their work is very isolated, very alone. They're going in and out of situations like this. And they often don't have, they don't have the water cooler or the coffee machine to kind of, and that I think is kind of absolute key policy challenge, which is instead of thinking of care as a sort of individual responsibility, you are a caring person, you've got a good heart, I think we have to think of cultures of care. And we have to think of a culture of care as being between the staff. I think care is always has to be shared, really. Otherwise it becomes too onerous. So the strength of the relationship between the staff is, I think, critical to how a care worker can continue to do the job. And that is, of course, a major priority, given that there's a recruitment and retention crisis. So keeping good staff seems to me to be a major priority. So the quality of the relationship between the staff, and then the quality of the relationship between the manager and the staff. Again and again, people said to me, they referred to their managers, and in one context, the manager made it all possible. The manager knew the job, had done it for years herself, and was so supportive and helpful and encouraging for people, for her staff. In another story of another private sector, both were private sector health care companies, that was one of the complaints. This manager had been brought in who had high heels and had never done the job. That was how it was phrased. High heels and had never done the job. She seemed to know more about marketing than she did about care work. She never came alongside us. She didn't really understand what we did. And as a result, the relationships broke down. And then, and the quality of those two sets of relationships will determine the quality of the relationship between the staff and the clients, which I think is absolutely at the heart of good care, is good relationships. And that is, it's a circle, it's a reinforcing circle. That sort of thinking about how care workers can feel part of a team, can feel a sense of they've got colleagues to help. And again, the care workers last summer, so this was after the book, talked to me about the recruitment and retention. It's like a spiral downwards. The more churn there is in the teams, the more time you're having to spend helping people to get experienced, the more difficult the job gets. You know, it works best when you have an experienced team who are used to working with each other. So I talked about a lot of problems, and I know that you probably know many of these problems, and one looks for kind of some way of kind of finding good heart. And I think the way I conclude in the book is that the strength and power of what I would call a gift economy, that care is ultimately a gift economy. People give of themselves to care for others. And when you have experienced good care, you know you've received a gift. It's not something that can be prescribed. And it is a moment of profundity. There's a recognition of sort of human solidarity that is so powerful. And again, people will say that when they've been in a situation and the care has been good, the care of their parents or the care in a hospital, or a deep appreciation. And I think that is the golden thread that runs through this, that if we can somehow reframe a narrative around that profound sense of human connection over the gift of care, that we could be on the way to being able to put social care on the same status as the NHS, which holds such an incredibly strong position in the British public imagination. And that really is the kind of driving point of my book, to say care is so valuable, it's such skilled work, that it deserves all the resources and investment and recognition that we can bring to it. And thank you for your time.
Thanks, Madeline, for taking us through your thoughts. Loads of comments in the chat. We're going to resist asking you any questions quite yet, but you can probably engage with the comments that we've received already. I really identified with your core messages. It's not a day to talk about the Wigan experience particularly, but certainly over a sort of 10-year period, trying to understand why there's sometimes an abstraction around the humanity kind of care and health workers, I guess, under a rule book doing the best, and making it more likely actually that our workforce feel like they're supported outside of a blame culture to do the things they know will work is really what's helped us over probably a 7 to 10 year period, aligned to things like the Care Act coming in legislation, which gave, I think, more of an empowering nature and maybe a paradise lost for some of the workforce to throw away a bit of the rule book and try things that will help people. You definitely really hit the core for us in Wigan, which is be kind, and the value of that being incredibly powerful, and that thing about actually care isn't a thing to ration. It's something you have all your life, as you say, to get in this room and to carry on, whether you're in the formal care system or not. Loads of takeaways for me, but I'll stop there because I know that Neil is going to come in next. Again, thank you, Neil, in advance for coming to talk to us today. Neil's, I think, with Social Care Futures, I know that, and an expert in human rights and the rights of people with additional needs in particular to have their best lives. So Neil, if you're here, I don't know, I think people are queuing the slides back up, but thank you, here. And over to you.
Okay, thanks, Stuart. And it's an honour to follow Madeleine. I've read Madeleine's book, which is fabulous and also deeply moving in lots of ways. So it's really and fascinating for me as well because of the amount of attention it pays to language and the language that's used in this area. I'm dialing in from London, where I moved accidentally 30 years ago. I grew up in Bolton. My mum lives in Tilsley, which is within Wigan, and Social Care Future was born in Manchester. So I kind of feel like I'm coming home a bit in this conversation. Social Care Future was born out of frustration, a sort of sense that despite all the progress that we'd begun to make, which Stuart alluded to around personalisation and person-centred care, it felt like we were kind of losing ground. So we were born of frustration, but we're powered by hope, really, a sort of sense that there is still possibility. We can still change this. We can do good things. We're a system change movement. We're about system and social change. Could I have the first slide? Sorry, man. Somebody else is doing my slides. Mana's doing my slides from a distance. So.
Apologies, I'm just frozen. Won't be a second. It'll take me a few seconds to resume.
Okay.
Thank you.
So we're a movement. I think importantly, we are a movement in which people who themselves draw and support lead the way. And that's very much central to the way we operate, the way we convene, the way we do our work. And I think that's crucial because the reality is, bizarrely, that's so often just missing from much of the debate. We don't hear the voice of people who themselves draw and support routinely in these discussions. We don't hear from people about their ideas, their innovations, the way that they would approach these things. We believe everyone should have access to the support to lead their best life. That's our starting point. I'm going to say more about that in a second. And our work really centres on three broad areas of activity. One is around shifting our imagination of what this is about, how people should be able to live their lives and how support can be organised to do that. It's about shifting expectations about what people should be able to do and the support they should be able to draw on. We're very much about building people power for the reason I've just alluded to. So we're doing a lot of work to make sure that the voice of people who themselves draw and support, or they may draw and support for somebody they care about, are central to these discussions going forward. And we're about promoting and trying to harness transformative innovation. We think the kind of models that still tend to dominate care have been pretty much designed 30, 40 years ago and haven't changed very much. And we all know that time and task home care is not working and it's not functioning well. We all know that we want to move away from large institutional care homes and things like that. But there hasn't been a lot of space for the kind of innovation to kind of grow between those two places. So we're about promoting that too. Can you launch the slideshow? I think we're looking at the. Is that right? Sorry, just bear with me a second.
It's not quite in the full slideshow format, is it? Although it's
Would
kind
it
of
be easier
legible.
if you can?
Apologies. I'm trying to
Why don't I share
see
my?
what the problem is, because I can see it in presenter mode. I don't know why it's not presenting on your side.
Okay, sorry,
Neil.
sorry everyone. Why don't I try and share my screen, and I'll try and do it from this end.
Okay, do you want to try to do that? Apologies for that. It's frozen on my side. It's not responding.
Oops. No, you're looking at my. Sorry, no, I'm having I'm having problems too. Hang on a second.
I can try again on my side if you want, but it's literally frozen. PowerPoint is not responding.
Right, hang on. Let me see. Okay. Okay, I'm gonna have to find a way to. I'm gonna have to take Madeline's thing. You'll have to look at my face instead. Hang on a second. We'll see if we can get it working. Okay, so as I was explaining, social care futures, a movement for change, focused on these different areas. But I think one of the crucial things to sort of say at this point is that despite our name, our starting point isn't care. In fact, I would probably argue that whilst it's useful to debate what care is, really what care is isn't the debate we should be having in 2022. Our starting or caregiving as a sort of starting point. Our starting point is about everyone being able to live their best life, and how we can organise things most effectively to achieve that. Right, there we are. Thank you. And I wanted to bring us back to the exercise we did before about home, in case you were sort of wondering what that was about. That exercise is something that we've done with our movement and in other settings. And what's interesting about that exercise is when you ask people what home means to them, people don't talk about walls and doors and ceilings. People talk about the things that you did, about love, about privacy, about family, about safety, about food, about their garden, about the things that they do at home. And that's because the things that we end up talking about are really about our personhood and our identity and the things that hold our personhood together. And that personhood is the foundation stone of person-centered care or personalized care. If you look at the writings of people like Tom Kitwood, who wrote a lot about supporting people with dementia in the 1990s, or John O'Brien, who really kind of led the way on thinking about personalized care, people with learning disabilities, both of them identified personhood as the foundation of our well-being, and noted that when our personhood is undermined, we experience ill-being. Our sense of well-being becomes depleted. And if we could have the next slide, please. If we accept that, then our debate shouldn't really be about delivering care. It should be about how to grow, nurture, sustain, or repair the things that hold our personhood together. So place, a sense of place and familiarity, the people and relationships that matter most to us, having a sense of purpose and the chance to flourish in our lives, and having a degree of agency, a sense of power and control. And I heard what Madeline said before, and I'll come back to those points around the sort of sense that we've pushed the idea of independence too far. Actually, I think what's happened is the idea of independent living has been kind of corrupted. It was never really about the idea of living without support. It was about self-governance, being able to live the lives that we choose to live ourselves with support. But all of these things on the screen here are fundamental to our sense of well-being, and they hold our well-being together. If we have the next slide. So do large custard slices. What I've said probably sounded a bit academic, and I just want to sort of bring it down into a kind of real world. The photo on the screen is my dad. My dad died in September 2020. He'd had Alzheimer's. And this photo is actually at Barton Grange Garden Centre, which a number of you may know. Seems to me in the Northwest Garden Centre is the place to go if you want to eat something good. And this was at the end of a rather odd journey. I went up for the weekend to support my dad. My mum went to see my sister in Edinburgh. And on the Monday morning, I said to my dad, well, what do you fancy doing? Should we go out? And he said, yeah, let's go for a drive. And I said, right, so where should we go? And by this point, his dementia was beginning to affect him a lot more. And he said, I can't remember what the place is called, but it's somewhere north of Preston. So we set off on this journey, and we were driving, and I kept saying, are you any clearer where we're going? And he said, no, but it's broadly in this direction. And I lost confidence in the end because we got a bit lost. And I sent a text message to my mum, and he said, have you any idea where we might be going? And then we carried on driving. And just as my phone pinged, Barton Grange Garden Centre appeared on the left. And it was odd because my dad has absolutely no interest in gardening whatsoever. And what was clear that even though he'd not been able to actually describe where we were going or tell me where we were going, he knew exactly where we were going, and it was to eat this huge custard slice. And that might sound like an odd story, but I introduce it because the reality was, up until March 2020, while the disease, while dementia was making life difficult, he was still at home with my mum. He was still among friends. He was still going to watch Lee Centurions and Sale Sharks. He was still seeing his granddaughter, and he was still eating large custard slices at various garden centres around the Northwest. His personhood was held together, and he managed to maintain a large degree of well-being. And of course, then all of that stopped, and he couldn't comprehend why. Home, for many of us, became a prison. My mum had no choice but to employ more coercion, because she had to protect him in the context of the pandemic. He only saw his family through FaceTime. There was no sport in person or on television, and there were no trips for custard slices. And an avoidable admission to hospital, during which he couldn't have visitors, brought his life to an abrupt, premature end. Ill-being took over. And while his death certificate said that he died of Alzheimer's, I think he really died from a loss of personhood caused by the lockdown. So I just wanted to tell that story because I think we have to bring well-being back into the centre of this and understand what it is that holds our well-being together. And it's not a revolutionary idea. So if we could have the next slide, please. Because the Care Act 2014, Section 1, is that the general duty of a local authority is to promote individual well-being, both by preventing, delaying or reducing the need for care and support, or by meeting needs. And importantly, meeting needs doesn't mean providing services or just providing formal services. The concept of meeting needs recognises that everyone's needs are different and personal to them. And the Care Act guidance goes on to say that care and support should put people in control of their care with the support that they need to enhance their well-being and improve their connections to family, friends and community. So if we could have the next slide, please. Even though that's the case, and even though we all recognise what's important to our well-being, as you all outlined when you answered the question about home, and even though I imagine many of you will recognise or have experience of a story similar to the one that I've just told, this isn't how we discuss care, and it's not how we think about care, and it's not how the public think about care. And so one of the things that Social Care Future wanted to do was to find a narrative that would change this story, that would help us to shift mindsets and build support for a different kind of future. And this is important because we think in stories. This is a quote: understanding means finding a story you know and saying, oh yeah, that one. Once we found the story, we stop processing. So the other thing that happened when we did that exercise before is you heard a word, home, and immediately before you even had to think about it, lots of thoughts and feelings and ideas were emerging. And you've not got control over that. So when we use language, when we use words, we tee ideas up in people's heads, we create feelings, we trigger certain values. Have the next slide, please. So what we've been doing, what we're looking at is framing. And one of the early advocates of this approach, Professor George Lakoff, has said that frames are mental structures that shape the way we see the world. In politics, our frames shape our social policies and the institutions we form to carry out policies. To change our frames is to change all of this. Framing is social change. This isn't just about messaging and kind of using the right words. It's about consciously using frames to change things, to actually achieve social change, which is why it's so central to the work Social Care Future is doing. Over the next slide. So framing is about making conscious and deliberate choices about what we do and don't say about an issue in order to influence what people think, feel, and do about it. And the next slide. Now, before I just get into the detail, we've also been following some basic rules about effective communications as well. And we've been learning for lots of different movements for change, whether that's the campaigns around equal marriage, work that's going around climate change, the work of Joseph Rowntree Foundation to reframe poverty. All sorts of different organisations and movements are thinking about language and framing as part of their change, and we've been drawing down on that. But some of the basic rules that we followed is, firstly, lead with shared values, not problems. Too often in the social care debate, all we hear is the system is in crisis and it's broken over and over again. We don't have anything that kind of inspires people's sort of sense of their values, the sorts of things that Madeline was talking about before. How do we generate that sense of shared commitment to one another? How can we talk about social care in a way that quite clearly, talking about the NHS invokes, it's about our identity, it's about who we are, isn't it? It's not just about a health service. How do we achieve that? And in particular, what we want to avoid is invoking paternalistic benevolence. I'll talk about this later, but we so often hear the language of vulnerable people or looking after the vulnerable, and we want to avoid that in our communications. Secondly, people buy the brownie, not the recipe. We want to talk about people living good lives first. We want to invoke a sense of a larger us rather than them and us. No more talk of vulnerable people. Just a quote here, Martin Luther King never gave a "I have a problem" speech. We want to talk about creating something good, not just making things less bad. We want to put forward our ideas as the solution rather than the problem to be fixed. Most of the time when we hear about social care, it's that it's broken, it needs fixing. We want to talk about it providing a solution that can make all of our lives better. We want to make hope possible rather than allowing despair to become convincing. We really think we need to ditch the talk of crisis in a broken system, or not ditch it altogether, but it has to be balanced with some sense that there is a way forward. If all we hear is that social care is in crisis and broken, in the end, anyone's sense of urgency that something can be done becomes a sense that nothing really can be done about it. And we also want to employ metaphor, mental shortcuts to help build understanding and shape the solutions people support. So if we could have the next slide. So just an example of this, it's from a study that Stanford University in the States did. When describing crime, it can fundamentally shift what people imagine to be the most effective solutions. So when crime is described as a beast preying on a community, people support draconian enforcement measures. But when we tell them crime is a virus infecting a city, they're more likely to support preventive interventions and treat it as an issue of social reform. So just a minor bit of language can radically change what people imagine the solution to be and their preparedness to support it. The next slide. I'm actually going to skip over this one just in the case of time, but just to say that what I'm about to share with you is based on extensive research, research that involved our movement coming together to talk about the story that they wanted to tell. It involved work with the University of Lancaster and the Frameworks Institute and others to try and understand what the current landscape of thinking was. Research with Equally Ours and Survation to really get to grips with the public's mindsets, the cultural models they relied on when thinking about social care. And crucially, persuasion, really working through how we could shift those mindsets and build stronger support for the vision that we want to bring about. The next slide. And I'm going to show you a short film that the Frameworks Institute, of interviews that the Frameworks Institute conducted for us that give you a flavour of how the public do think about social care now when asked what it means to them. If you could play that, Anna.
Okay, I'm going to try this now, Neil. Hopefully we won't have any audio issues. If not, Manara's going to jump back in, so fingers crossed. Okay.
No, there's no sound. Yeah, I don't think you've put the sound on when screen sharing. If I get to share it later, I will. Let's just jump ahead, otherwise we're going to spend ages trying to fix it. The next slide kind of summarizes what came out of that exercise. We can move on.
Manara, are you able to move on?
Okay, so that was one of the things we did, was talk to people on the street, and we asked, it was a similar exercise to the one you did before. We just said, you know, what does social care mean to you? What comes to mind when you hear the word social care? But we also analysed about 5,500 newspaper articles. We looked at how advocates for change talked about social care. And then what we mapped was what the current public story was set against the story that we're trying to tell. So as I said at the outset, our story is about having a life. The public story, very much just about people being kept alive. We see social care as a vehicle for that good life. The public story tends to position social care as a destination. We heard this a lot during the pandemic, and people like Matt Hancock would talk about people in social care all the time, as though it's a place that you went to. Our story is about people caring about and supporting each other. The public story is very othering. It's about looking after our most vulnerable. Our story is about nurturing relationships and connections. The public story tends to centre on the idea that social care is a sector or industry delivering a service. We talk about people with gifts and potential and how support can unlock that potential and those gifts for the wider community. The public story is very much just about people with needs. We talk about the growing value of great care and support. The public story is very much about the growing cost of life and limb care. So we'll hear metaphors like a silver tsunami and a demographic time bomb all the time. Our story is about investing resources. The public story is very much centred just on spending. Our story is about how everybody can play a role in this, including government. The public story tends to be that only government can fix this. And we see it as an opportunity to come back to the point that Madeline made, this great achievement of our longer lives, but we've not made these adaptations and made these investments to show that we can actually reap that longevity dividend and we can all live well. The public story is purely one of crisis, something we have to constrain and contain. We have the next slide. So where did that take us and all of this work? I imagine some of you, I hope some of you will have seen this, our North Star, the kind of vision that we shared. But this didn't much change through all the work that we did and all the public audience research. And it's been used very widely now in Parliament, by the Labour Party, by various charities, by the LGA, lots of different organisations have kind of drawn on it. But I just want to kind of unpack it for you. So, you know, it begins, don't we all want to live in the place we call home, with the people and things that we love, and communities where we look out for one another? What's this doing? Well, firstly, you'll notice it doesn't talk about older or disabled people. It doesn't even talk about care. It's a universal idea. It's addressed at this larger us. It's addressed as everyone. It's about the brownie, not the recipe. So it's about the lives we should be able to live, rather than talking about the kind of mechanics of a system. But it also invokes shared values, and it tries to shift the values. So rather than relying on these ideas of benevolence and in a negative sense around vulnerability or the kind of othering that can come with that, it's about self-direction. So it's about being able to live our own lives, but it's also about belonging and security, as you all sort of, many of you pointed to, sort of sense of safety and security and feeling anchored in your life. But it also, again, to address Madeline's point, tries to invoke community and reciprocity, the idea of looking out for one another being fundamental to a good life. And then finally, also, as I'll come on to say, position social care as the means, not the ends. So it's not about going to social care or accessing social care. It's about our life and being able to live a good life. Can I have the next slide, please? So there are three things here because we tested different ways to talk about it. But I think that this part of our narrative is really, really important because it does a number of things. The first is this phrase, and you probably will have begun to hear it now. And it's interesting because it was the one bit that we didn't actually test. We kind of included after the work was done, after the research was done. But this idea of people drawing on support to live their lives. So not care being delivered to them or people accessing social care, is back to this point that this is about support to live our best life. And we used a number of kind of metaphors to try and kind of get this idea across, as well as the idea of social care not being this one thing delivered to people, but it being about stitching various resources and supports and relationships and things together around the life that the person wants to live. So we talked about social care as the glue that binds together relationships and support. We talked about social care as helping to nurture an ecosystem of relationships and support. And we talked about social care helping to weave the web of relationships and support in our local communities that people can draw on to live their lives in the way that they want to. So this is a kind of shift, and it's a shift that also reinforces the idea that the important issue is the person and their life. a lot of the social care narrative doesn't talk about people, bizarrely. It talks about the system and the social care sector, and it actually makes it the primary kind of object of concern. We wanted to change that to make sure that this was always stories about people and their lives. And this is relevant, I think, also to issues in the here and now rather than just in the future. If we actually take this as a template, if we think about the kind of challenges that are faced right now, we talk about the challenges of the workforce of existing providers, but we could in fact talk about the challenge of the supply of support and its effectiveness at connecting people with things that sustain their well-being. We very much focus on the whole issue of hospital discharge at the minute, but will increasing the availability of 15-minute time and task home care visits really help people stay out of hospital? Or do we also need to be looking at relationships and people having purpose to maintain their well-being, and those things are equally important? We talk about wanting to digitalize social care delivery, but maybe we should be talking about how to harness digital technology to empower people to transform their lives. And the next slide, please. Okay. And the other thing, I won't spend a lot of time on this, we've not used it much, but one of the things that we wanted to challenge was this idea that the answer just lay with government. And I think we know the reality is the answer doesn't lie with central government. Yes, it lies there in terms of commanding the resources, issues of regulation, creating the most fertile environment for these things to happen. But if we keep imagining that central government is going to give us the direction that we need, I don't think we're ever really going to achieve change. So we wanted to paint a different picture. We wanted government to invest in social care, make it a priority, but we also want councils to behave differently, you know, to extend models like the Wigan deal and embed them much more deeply in the way that social care works and the way councils work with local communities and voluntary community organisations. And just quickly, just the last couple of slides, please. What effect did this have? This is from the polling research, the qualitative and quantitative research that we did. Having been exposed to this narrative, the participants, there's about 3,000 people that we polled, they were significantly less likely to associate social care with paternalistic ideas such as vulnerability and compassion, are far more likely to associate with words such as independence, community, and relationships. And more people agreed with the statements that social care is about people having the support to live how, where, and with whom they choose to, and that it draws together relationships and support. So we managed to achieve that shift away from the idea of social care just being about services delivered to people in their own homes. And the next slide, please. And I think this is crucial. As a result of this, people were far more likely to regard social care as important to themselves and those close to them, far less likely to just imagine social care was always about other people, which is one of the things we noticed through the initial work that we did. Far likely to regard social care as a benefit to both those who need support and the wider community. And they were more likely to accord greater priority to social care above other areas of government policy. They were more likely to support investment in social care from central government and to believe that it was possible to start organising social care in a better and more sustainable way now. And I think this is really, really important to come back to what Madeline was talking about before, about a lack of value attached to care or to care work. I think sometimes we think the answer to that is to centre on just valuing carers. Our argument would be we need to actually change the whole kind of narrative and how people think about the value of support in their lives. We need to change the way people think about older and disabled people, as well as people who do care work, if we want to achieve that shift. But I'll stop there. Sorry, I've gone over a bit.
No problem, Neil. It was, again, like Madeline's, really thought-provoking and set my mind racing. I'm actually, if I wasn't paying full attention, Neil, I'd be looking out on a playing pitch at Leigh Sports Village. That's where I am today. So I don't know if your dad saw Leigh Centurions play here, but
yeah, well, every home match, yeah.
Yeah, so that's where I'm. This is where I thought my Wi-Fi would work best, and I wouldn't get interrupted at my home. So colleagues think that we've a better chance of getting the video to work, Neil. So I don't know if do you think it's worth us just trying one last time to tee it up?
Yeah, I think it's probably good for people to hear that if you could.
Right, have a go then. Charlotte,
I'll have a go at that.
Be prepared, Charlotte. Just tweak a bit on the time span of our input later on, because I think we need to do justice to questions from the floor for Madeline and Neil. So if you can just prep to clip the input accordingly.
Okay, thanks for sharing that. I think that sort of brings to life, hopefully, what I was talking about before. There are some positives in there, people, and it comes back again to, I think, to what Madeline was saying earlier. People expressing a sense of commitment to one another, people invoking human rights, a sense that we should support other people. At the same time, not one of those respondents talks about social care as irrelevant to them. It was always about other people. They used the vulnerable word repeatedly throughout it. So the idea that it was just looking after vulnerable people. I would point you to Bryony Shannon's great work on that. And they imagined that the problem was one of money, but what's interesting about that is that they didn't really think we had the money there. So there's a sort of sense of despondency, a broken system, expensive to fix for other people, but we're probably not going to be able to do it. And I think if we don't change that narrative, we're going to be in the same place 5 years from now, 10 years from now. So that's why we want to do this work. Thank you.
Thanks, Neil. It's really brilliant, and I think it's the right challenge from the Social Care Futures movement, from my point of view, in terms of there's loads we can do locally, even if we don't always think we've got the ideal resource allocation in the starting point or whatever. I've asked just in the chat for people to, we got loads of kind of responses as both Madeline and Neil were talking. So we'll try and collect any kind of thoughts and questions through the chat, but I suppose just to get it going, and it's a bit of a specific one, and Neil or Madeline, you may or may not have views, but it's just to get the ball rolling. I'm thinking about the sense of that repositioning of social care and the cultural issues that you've both touched upon around being something that is, it's not abstraction, it's not another, it's of incredibly strong value. My context, I suppose, is integration and the NHS and care sharing that sense of repositioning and reframing. And it does seem to me sometimes, even however hard we work locally with brilliant relationships with primary care colleagues, with the local hospital, that there's almost a juggernaut around social care being a solution to hospital flow, perhaps, and again, quite a technical and managerial approach to the performance management in those systems, regardless of the caring heart of professionals and managers leading them. So I just wondered, maybe to start with you, Neil, and then Madeline, if you've any thoughts about the kind of positioning of that reframing challenge across public services, if you like, and particularly the NHS social care interface. Can I pick on you, Neil, to come back in on that?
Yeah, I mean, I think too often, this isn't universal, but too often the kind of narrative in the discussion is almost treat social care as a storage solution. So where can we put these people? I mean, the term bed blockers been kind of oddly used in Lancashire a lot. I don't know why. It seems to be slightly endemic. I keep reading news stories from Lancashire using the word bed blockers, which is a disgusting phrase, because the reality is that people are stranded in hospital. They're not a problem, but the problem is centering on them. So it's this kind of rather limited idea that social care is just a sort of foot soldier for the NHS, and it's there to sort of where we put people when we can't keep them in hospital. I come back to where I began, and I think whether we use the word well-being or some other kind of terminology, I think that the reality is people are, I mean, my mum's just not been very well for the last few months, and I sort of think about what was sort of driving that, what was behind it. It was a lost sense of purpose, it was disconnection, it was kind of loneliness, it was all those sorts of things which, you know, time and task 50-minute home care visits are not going to go anywhere near. So I think we have to open out this idea of kind of well-being and what fundamentally supports people's well-being. And I think that could be the best focus for integration between health and social care, if there was that kind of co-ownership of that with other kind of partners in communities and with people to try and generate that. We've talked about prevention for years, but we're not making those investments. And I didn't have time during the presentation, but my mum and dad really benefited in Wigan from a community circle, and it was transformative in terms of drawing together the kind of threads of family and neighbours and others to sort of support them. And my dad's still been able to go with his mate to watch Lee Centurions and things like that. I think those are the things that we need to be focusing on if we really want to make the difference.
Thanks, Neil. And I can see Andrew drawing on previous contributions in the chat, was talking about that collective sense of community resilience perhaps having been strengthened in the pandemic to an extent, and maybe the ability to draw that through in meaningful ways. Madeline, did you want to make a comment on my original kind of question, or anything that flows from it that Neil said?
Yeah, I mean, I was interested by Neil's comment of the sort of social care seen as a storage solution, and I love what Neil was saying about community circles and that sort of well-being agenda. I just wanted to add a sort of historical context, a little bit of historical context, which is that the sociology of aging concludes really that the West has never had a system for valuing age or cultural value on age in the way that the East has done. And I think that the problem, part of the problem we've got, and there's a slight difference between Neil and I, which I think is a very creative tension, if you like, about, you know, me coming in and saying, let's call a spade, this is a crisis, let's name it because it is about vulnerability, and Neil saying, let's use other words. And I think we can, you know, creatively explore that about sort of, because it seems to me that part of the problem about our undervaluing of care is about our undervaluing of certain periods or forms of human life. So one care worker said to me, she was really good at her job, but she said to me, let's face it, what I do is not great, because actually, you know, these people, what are they to do? You know, what's the value of their lives? And this was a throwaway comment she made to me after I'd written the piece about her at a Joseph Rowntree event in London. And I was so shocked. And I thought, how is it that our culture and society has somehow communicated and expressed to her that somebody with severe disabilities, an adult with severe disabilities, their life is not of value. And I think that problem runs through the care of the elderly and the care of people with disabilities. So I love those pop-up interviews that Neil had in his film. Somewhere deep down in our culture, there is this value, this recognition and appreciation of human rights, and you know, we do need to care for those in our society. You know, there is that sense of decency. And we need to sort of build on that sense of decency against what I think it sort of undermines it, which is a really ruthless valuing of human life, which I would argue is about how capitalism works, consumer capitalism. You know, you're valuable insofar as you work and insofar as you are an efficient, effective consumer. And if you don't do those activities, you're kind of human waste. And I do think these are really pernicious attitudes that sort of creep in a very corrosive way. So, you know, how do we challenge long-term traditions which have not valued age, contemporary valuations which are ruthless about assessing whose life is valuable and whose is not? I think a movement, as Neil describes, is really, you know, this is about cultural change, which will enable the space for policy change.
Mm-hmm. You're getting applause. I've just found the Zoom reactions myself. So there's a couple of people applauding that, Madeline. And Jackie, I think, has got a hand up as well as applauding. So Jackie, was that to come in with a particular question for Neil and Madeline?
Yeah, I think it was just an observation and a comment. I found, you know, everything this morning very inspiring. I think it's really important as leaders, you know, that we really embrace the narrative around social care and try and shift that dial. I do think that you know, there's a lot of there hasn't been a lot of understanding around well-being and the well-being principle that's placed within the Care Act. And I certainly think, even from a frontline practitioner point of view, then that understanding of well-being has just been missed. It's there's still very much that sort of possibly process driven. There's some creativity, I'm not saying there isn't, but there's very much an underlying, there's not been as much of a shift with the Care Act coming in as I think initially anticipated. And I think as managers and leaders, I think we've got an integral part to play in trying to shift that slightly and allow, you know, an understanding of well-being, understanding of intrinsic value. Everybody has intrinsic value, and everybody, you know, should have opportunities to live well and be their well-being. So I think, you know, some of it is really inspiring, and it's about how can we then practically, you know, build on that to make sure that you know those pockets of this, and I know there is pockets of it, just become bigger, so that they, you know, and bigger, because I think at the moment they are pockets, and there's creativity and aspirational work, but it's just not big, you know, in terms of making those systemic changes and shifts. But I think, you know, it's been really thoughtful and thought-provoking and inspiring for me, because you know of what's being found, and it's not surprising, but you know, I think it's really good to continue to talk about it and take it forward and start, you know, working with it as leaders.
Thanks, Jackie. Can I combine that with probably with Ruth's input in the chat and Madeline's response, and perhaps a last question to wrap that together? I suppose I'm thinking about, you know, kind of a cultural or societal movement for change, and that there've been plenty of, you know, there's bits on the kind of NHS side around, you know, the NHS Alliance and infecting the NHS with wellness. There have been various kind of advocacy groups and user-led movements for social care and change. And there was a question in the chat around, you know, how do we get to a kind of broader alliance of movements for change? And Madeline, you put an initial response in actually to that. So could I just pass to you to sort of, you carry on the conversation, and then perhaps to Neil for some final thoughts on how this becomes something that's almost irresistible, if you like, in terms of cultural change.
Yeah, I mean, I think the model here would be around sort of mental health, which, you know, over the course of the last 10 years, I think there's been a very dramatic reframing about mental health. And one of the ways they've done that is by destigmatizing it, by kind of remove. So, you know, you have Prince William and Catherine talking about mental health. You have, you know, actors and celebrity figures, all kinds of people saying, you know, I've been there too. I know what it's like, depression, anxiety. So these were panic attacks. I mean, 15 years ago, you know, people didn't really much talk about that kind of thing. And now I think it's kind of absolutely open. Whether it's led to the kind of shift in resources on mental health is another question. And I think that's an interesting and important question. You can have the cultural change. How long does it take for the kind of investment of resources to catch up to get the adequate mental health? But I think if social care sort of thought about the way mental health has done that, and I think there's potential for that, and actually thinking about it, I think it's a really creative area to pursue. You know, what happens if we have really, really, you know, great young celebrities saying, my granny had fantastic carers and I am so grateful, and when I was at my granny's funeral, they were there and I couldn't thank them enough. You know, that to connect to a younger generation, because I think it's that younger generation connect that doesn't happen. People think social care sort of is for, you know, decades in advance. I don't need to think about it, and hopefully I won't need it. And we were all very good at that because none of us want to think about getting old. So, you know, that's part of the kind of cultural challenge. And, you know, wow, could one do something really interesting if we found a footballer who would say, you know, hand on heart, one of the most powerful emotional experiences was seeing a carer looking after, you know, helping me look after my mum. Can you imagine what that kind of, how that would resonate, you know, with new audiences?
Yeah, and it actually, mechanically, dementia actually being an experience which footballers are increasingly going public on, you know, earlier in their lives perhaps than others, is a technical connection to some of that reframing in the general population. Neil, did you want to offer any other reflections on that, broadening the movement, opportunities or limitations to that, or your own perspectives before we move on to the next block of input?
I mean, we've just this last week received a modest grant from a funder and a provider to develop a proper campaign proposition to do what we want to do, which is kind of a long-term shift. And it very much centers on what Madeline's saying. We don't want it to be about the mechanics and the policy. This has to be about culture. You know, it has to be about who we are. And it's a kind of who are we discussion first before it's a kind of how do we actually organize funding in a really kind of complex way. So we're hoping to pull that together and to talk to lots of people and to kind of mount that campaign soon, or begin to mount that campaign soon. For me, one of the biggest inspirations at the minute is the Caring Across Generations movement in the USA, which has had a huge kind of impact. I mean, it's managed, interestingly, one of the cores of its framing is to frame home-based care as essential infrastructure. And that ended up within the kind of Biden administration's language, and there was a major kind of investment, or an attempt at a major investment behind that, almost positioning home-based care alongside roads and bridges and things like that, to trying to change that debate. So there's some very interesting kind of reframing and thinking going on there. But go onto their website, look at the films they produce, follow them on Twitter, because it's nearly all these big who are we questions. It's about people and relationships and care within those relationships. So there's a lot of inspiration out there and things we can do. But just quickly, I do have to say, I think until we actually manage to shift attitudes to aging, to older people, to disabled people, we won't shift attitudes to what care is and what it does, and vice versa. There's a relationship between these things, and that's what our narrative is trying to do. And it's also the reason why we want to foreground people who themselves draw on support as spokespeople within this, rather than just as objects of care.
Thanks, Neil. That's really, I think, rich reflections from both of you. I've figured out how to do applause, I think. So I'll give you both a clap from me for the inputs and stimulate. You've probably seen my reaction as well just earlier in the chat. I think we have an okay strapline for the 2030 work, which is about every day the best it can be for people in receipt of any of the support in social care. But then I think we flip into some quite technical industrial language unnecessarily in the way we describe, we're essentially trying to put in person-centered models around people's whole lives. And I think we could reflect on that in the way we describe our own strategy and get closer to the core of humanity and culture change. And I think some other comments in the chat had said, what would a Northwest narrative look like, that was speaking a bit more to Madeline and Neil's sort of exposition. So we're definitely going to work on that and think about it together. Charlotte has got a really tough gig here, because not only are we've eaten into your slot a bit, Charlotte, but you're following two excellent inputs. But I know with a really authentic run through of the Cheshire West and Chester journey on reframing and repositioning adult social care in a place in the region. So what I'd say is don't rush it too much. I know I've said, can you grab us some minutes back? But I think we'll also be able to pinch a bit of time from the group reflection time that we've earmarked subsequently. So we still want to do that group chat time justice, but don't rush us too much to get us there, Charlotte. And thanks in advance for your input too. And again, a big thank you to Neil and Madeline. Hope you can stay on, understand if you can't, but it's been brilliant to have you here. Thank you. Charlotte?
Great, thanks for that. And yeah, I can capture some time up, and two fantastic presentations to have followed, and a lot to reflect on there. So if we just go to the next slide, just as a quick overview, recognise really I'm kind of touching the surface today, but hopefully what I'm sharing will resonate with a lot of you and stimulate and further the discussion that we'll have. This is really just a run through of how we're sort of developing our vision for adult social care in Cheshire West, and a quick look at where we were pre-COVID, where we are now, and how our vision's developing, the impact of our vision and values on how we work, and slipping into tech speak, which I think, you know, we're all now going to be much more conscious of, but our models of care, or our approaches to sort of development, how this is influencing or needs to influence our approach to integration. And within that vein, the importance really, I think, of us achieving shared vision and values. So next slide. So back in 2018, we launched what we call Pathway to Independence of our vision. And just to pick up on that really important points that both Neil and Madeline have made, that use of the word independence, and absolutely not about not needing support, because none of us are independent in that definition, but maybe care around that word. And that was launched, and the vision was around integrating effective and high quality services, support residents in the most appropriate setting, and that the adults are compassionately supported to lead fulfilled and independent lives. Next slide. And this just kind of summarises the approach that was taken. It was very much a redesign at that point of the adult social care in Cheshire West, looking at staff behaviour and cultures and working practices, and very much trying to focus on that sort of independence, early intervention and prevention, and looking at our use of technology, support and recovery at home and in the community, personalisation, trying to be efficient and effective, in particularly in terms of the use of resources, support for long-term conditions and crisis avoidance. Next slide, please. And the sort of outcomes that we were looking to achieve at that time were around joined up support, quality services, people telling their story once, that whole right service, right time, right place, that people felt protected and safe, and that you know, residents could see they were getting value for money, people were empowered, and that staff were empowered. Next slide. So really then just looking at how far did we get with that, because I think initially it was a lot about structural changes within the department, changes to team remits and skill mix. There was a strong focus on redeveloping the front door and the approach when people first make contact, a fresh approach to reablement and reviews, an OT first ambition, and the beginning of a change to commissioning. And as part of this, we developed a dedicated review team, occupational therapists placed at the front door in every community team and in the review team. But of course the pandemic came along, so that I think sort of delayed the continued development really of that strategy and approach. We saw, and we're still seeing, increased demand for services, intensified workforce and care challenges, those continued funding pressures, and that certainly hasn't gone away. But we also started to see improved relationships with our health colleagues, but also with service providers, with care home providers, with care at home providers, and with our community groups and community and voluntary sector. And it brought about some real opportunities, some innovation and pace. We suddenly were able, as health and social care, to do the things that either had felt too difficult or that we couldn't do previously, and some of those long believed barriers and things that prevent us moving forward and making change actually suddenly weren't there. So a lot of learning really and reflection. Next slide. So it was really a time we felt to reflect, to sort of pause, reflect and reset our vision from all the learning and the change and changing approach really that we wanted. So next slide. We felt that we had some strong branding and in the original work that we'd done, so around Pathway to Independence, and critically practice to be proud of, and that's something that is really important and resonates with our workforce. And this was known and owned by our workforce. So the last thing we wanted to do was everybody feel like, oh, here we go, we're starting all over again, throw everything away. What's the next whim or phase? And certainly a lot of the values were held incredibly firm during the pandemic. And I've certainly been incredibly proud of the way our social care workforce adapted, the flexibility and creativity that they've shown, and the commitment to the people that draw on our services. So we've taken a lot of learning from this period really to influence how we move forward. And we recently celebrated National Social Work Week. And as part of that, we produced a tree of hands, and we asked our social workers to create handprints and to write in what social work and social care means to them. And if we just go to the next slide, and I guess it's picking up really on a lot of Madeline's presentation really, and Neil's around the power of words and language and narrative. And these are the sort of the words that our social workers used, and I think, you know, shows really strong values, and positivity and energy really stands out, and I think gives us a strong basis, we feel, for it to continue to sort of transform our services. Next slide, please. And so as part of this, we've established an Adult Social Care Commission. This was the ambition of our lead member for adult social care and public health, who's showing real leadership and real determination. And the approach was endorsed by our cabinet in September last year. And we started in November. We've had six sessions really of the commission. One very much focused on developing our vision for social care, one focusing on funding and paying for care, the role of communities and the importance of engagement, workforce, and that whole breadth of issues that we know are there, but also opportunities around approaches to workforce, technology, and then commissioning high quality ethical care and what that looks like. The commission panel has been made up of cross-party members, community and voluntary sector, and NHS representation. And across all of the sessions, the panel has heard from people with lived experience, people who draw on services, user-led organisations, service providers, North West ADAS, other local authorities, and Stuart, who's chairing today, came and presented the Wigan experience, and a whole breadth of organisations bringing some real insight and expertise, and a real wealth of knowledge and experience for the panel to hear. And all sessions were open to the public. We didn't actually have any public speakers, but that opportunity was there. They've all been broadcast live, and the recordings and all the sort of information used is hosted on our website and available, and I've put the website details there. The sessions really are worth listening to, and some really inspiring and challenging views and approaches really for us to take moving forward. And the real objective of that, to shape our future services so that residents can be supported in achieving their aspirations for a healthy, happy life in a place they call home, playing a part in their family and community as much as they wish. And that will be reported back to Cabinet in July. Next slide, please. And as part of that, we want to be sure we're aligned to the vision and values that are in our council plan and in our place plan. And in Cheshire West, our place plan is also our health and wellbeing plan, and sets those priorities. Our council plan about greener, fairer, stronger communities and the place plan to reduce inequalities, increase years of healthy life and promote mental and physical health and well-being for everyone in Cheshire West. So we need to be sure that all of this is aligned in how we move things forward. Next slide, please. So in terms of our approach to this and some of the key messages that are coming through, but the premise on which we're already working, and obviously will be much more informed by our Adult Social Care Commission, but very much focused on being strengths and asset based. I'll come on to community-led support, but we really holding that as the way that we move forward as adult social care. A strong focus on prevention and early intervention, and really about what matters to people, having very different conversations and being sure that everything we do is person-centred. We've had strong messages throughout all of the Social Care Commission on the importance and value of co-production, and we're certainly beginning with co-production. I can't, pretend to say that we're there and that it's fully embedded in everything we do. I think we co-produce at an individual level when we're working with people, and we're much stronger at that. But in terms of how we move forward around our commissioning and service development, we're really beginning to embrace and develop that real commitment to co-production. And we've got that evidenced at the moment with our approach to our community-led support work and our community services, and what we used to call our early intervention and prevention services, and how we're looking at that commission. And what we know we need is a real culture shift to embrace all this, not just within adult social care, but across health, social care, our communities, across our whole council. And we've done a lot of work around this sort of vision and approach across our council, very much about empowerment and trust, both the people who are calling on services, that are our providers, and the businesses that we work with and the organisations we work with, but equally the empowerment and trust of our workforce. Embracing technology, and that full embracing of home first. It kind of feel it's been a bit hijacked by the NHS as it's just about a destination from hospital, but actually embracing it as we work with people at home in their communities, and that's where people in the main want to be. I've mentioned that it's a kind of a fresh approach to how we're approaching commissioning, and a huge amount of work around workforce planning and sustainability and that sort of care market, and again using an industry term, but sustainability, and really appreciating that it can't just be about how we've always done things. Very much about diversifying the offer, that real shift away from this is the menu of what's on offer to people. Maintaining clearly strong safeguarding as we work through this, but a real positive attitude to risk. Our approach to quality assurance and what good looks like and who tells us what good looks like. And obviously what we do has to be sustainable. And we're looking at all of this around the footprints of what we call in Cheshire West our care communities. And these have been developed, that they are the primary care network footprints. But very much looking at our communities, at services, organisations, people coming together around their sort of community footprints to influence and shape and set the priorities for communities. And we have steering groups that are across all sectors, have member involvement, and very much sort of primary care involvement, and they've just won actually a national improvement through co-production award, which is, I think, real testimony to us, what was intended to be a kind of a grassroots approach to developing our community work. So still very much in early days, but great to have their work recognised. So I've just come on to the next slide. So all of this really has led us to adopting in Cheshire West our community-led support work, and we've developed a really strong partnership with the National Development Team for Inclusion, and they're supporting us really with this. And it's not a project; it's a complete change and transformation and refocus really of how we do our work. And we can see I've put this sort of slide. This is from NDTI, but it shows really how broad this work needs to be if we're really going to have impact and make the difference that it needs to have. So it's very much about the involvement of people, partners, and community in shaping solutions. And I think, you know, we've heard that really well already in that's where we need to be. Streamlined and joined up processes and decision making that are close to the person. So, you know, I feel one of the big things as leaders is we need to be sure, you know, at worst we don't get in the way, but at best we need to be sure that we're removing the things that do get in the way of everyone actually being able to do a great job and make a difference. It's about shared values and principles across all partners that support people locally. And I think that shared values and principles is really key and really important as we're moving into this sort of greater world of integration, particularly across health and social care. It's very much about a culture of trust and shared responsibility. And as we said, that positive risk taking, which we all do in life, but we seem to sometimes shy away from when we have to become involved in people's lives. That people are listened to with good conversations, and that we understand what matters to people. Strengthen professional autonomy with peer support, and I think that's really came through. I think a really interesting point around, I don't know if I dropped out then, sorry, but about that peer support is really important. So actually professional autonomy is not about working alone or feeling that people are working alone. It is about brave leadership, and that's a word we're using an awful lot at the moment, that teams and people work together and in a joined up way, and that learning and evidence of impact is captured, and that's we're trying to do that not in a bureaucratic way or a way that feels like we're counting and we're not setting targets. This is not a program management approach by any means, but trying to take the learning and the evidence so that we keep moving this forward in a positive way and learning from elsewhere as well. If we just move on to the next slide. So just to bring this to life a little bit, in terms of where we're at with community-led support, we developed what we've called Let's Talk Ellesmere Port, which is basically we're based in Ellesmere Port Market, and it's a real shift in how our front door, transforming our front door really. So trying to position ourselves to be able to have meaningful conversations in places that people are. So people can come and talk to us, and we've got a range of partners, Citizens Advice Bureau, etc., who are a part of this as well, or can be directed there when ringing our sort of front of house, our community access team, so that people can talk and have support before they hit crisis, that we're not just dealing with people at that urgent point, and that we're far more visible. And this is our first sort of trial at that. We're taking the learning. It's very much being led by the staff and our sort of social workers, social care assessors who are attending and running these sessions, and it's developing kind of a life of its own really, and very much evolving, and we'll take the learning and kind of roll that forward. And we've done a lot around trying to remove bureaucracy. So a simple thing, really, one of the early changes that we made in the early phases of the pandemic to allow people to be able to work creatively and genuinely work in a strengths-based way was to kind of throw away and redesign our assessment and care and support planning tools, and that they were done and designed by our practitioners. And I have to say, it's probably been the smoothest and most positive launch of new assessment and care planning tools that I've ever known. And the key there being, ask the people who know and let the people who know just get on and do, really. And I suppose one of the important things for us is that we've got full support and buy-in from our cabinet and whole council on this. We're fortunate, picking up on Neil's point earlier, that we have a cabinet who are absolutely committed and focused on strong community and that community engagement and involvement. So this really chimed with them, and we've got really good support across the council, and it's really helped to reframe our approach and relationship with our voluntary and community sector, who are working brilliantly with us. And it is influencing our thoughts and approach to integration. So if we just move on to the next slide. I'm sorry, I'm conscious of time. So yeah, on top of all of that and all the changes that we need to make, obviously we've got the changes in the NHS and the integration approach. And I think it brings real opportunity, but for me, more critical than ever, that we have the social care vision and values that are strong and clear and understood and influence how we move forward. It's critical to recognise that we have got cultural and organisational differences, and we need to work through those. So our approach, just in a nutshell, really, to integration is that we integrate if it's about improving outcomes and where there are clear benefits, and it's not a destination or an endpoint in itself. I think we need to be sure, really, that through all of this work that we're keeping our heads up. This doesn't just become a structural exercise, and that we continue to look through the lens of our care communities and citizens and people who need to draw on support. And for me, we really need to hold true to all of the community-led support principles and values if we're to achieve the shared transformation required, and that move away from trying to fix the same problems with the same old solutions that we know don't work. But I think there's a danger that under pressure, that's what we still get pushed to do, particularly through the lens of the NHS and the pressures there. And there's a danger that sometimes we do something that we think looks new and different, but really it is the same thing, just slightly reconfigured or remodeled, and we really have to to resist that. So just moving on to the next slide, and I think as part of this, we really need to be sure that there's a change in the conversation. Acute hospital care dominates the focus, and I think we understand that there's significant pressures, the demand and the extent of recovery that's required in the NHS, and particularly in the acute services. And acute pressures are very visible. An overflowing emergency department is visible to all. People in beds who are waiting to be discharged can be counted, and I think waiting lists are routinely shared and monitored at a national and an ICS level. Social care pressures are equally there, but are less visible, less reported, less recognised, but they're equally as acute and impactful on people's lives. I think that there's recognition that we need strong community services and strong communities if we're going to move away and do anything really to address the pressure that the NHS is seeing at the moment. We've set this sort of discharge to assess and urgent community response are our first place priorities for integration, but we quickly need to shift that to be about that really strong community response. We have got system recognition and ownership now, so that's across health and social care about our care at home pressures, for example. I think, you know, some of the real positives that we've seen, we've definitely moved away from the finger pointing and the blame culture that maybe existed previously, and certainly we're working jointly on new models and how we work with our care at home providers, and how we move funding around from particularly from acute into community to support some of the issues there. And I think we have got greater recognition at both our place and at the integrated care system level of the need to move funding around the system. We just need to see it happen and think about how we make that happen. And I think for me, a clear vision and narrative for adult social care is critical to influence and shape our place priorities and investment and how we work as an integrated system. So just as a final slide, I think, you know, we need a strong adult social care vision, values and narrative, but I think we need that to be a shared vision, and partnership, as we've all seen, is really key. And as part of that, we have to listen and collaborate with our citizens, communities, and those organisations providing our services. So we need a shared vision for health and social care in Cheshire West. We need shared commitment and ownership, but critically, as well as the words, we need to be sure that we've got that shared understanding as well. So thanks everyone for listening.
Thanks, Charlotte, for taking us through that. I've got a question for you, but it might be, if you can just put it in the chat, maybe if you get a chance. It is whether from Neil and Madeline's earlier contribution, whether there are any reflections and takeaways for you back to Cheshire West and Chester that might, in their own way, amplify or reposition any of the local work. So I think you're giving a real honest account of working in a place with the integration agenda, working in a place where demand for services is high, resources are stretched, and a real kind of, this is how things really are. So it'd be interesting to just get a sense of those reflections. We didn't manage to grab any time back, so I'm going to make a methodological change, I think, to the next block. We were going to ask people to, whiz away through the power of Zoom into breakout rooms to consider 3 potential questions, but I don't know if we had the ability to sort of beam the questions we were going to do in smaller groups into the main room, and then perhaps in the way in people piling into the chat or sticking your hands up. So we've got sort of 3 questions here that we were looking to get your ideas about. So you can read them if you can read that slide on influence the narrative. We did want to try and do the Slido at the end as well, so if colleagues can be ready in about 14 minutes time, depending on how we do with this slot, to log the Slido back up, because we did want to reposition that home question we asked before around care, and to see what comes through on the back of the inputs this morning, and to compare and contrast. But with these sort of questions, in terms of those of us who are on the call, what does care mean to you in your organisation? How does adult social care as a sector and service fit into this? There's an interesting one poking at the kind of NHS to social care interface. How do health colleagues perceive local government, directors of adult social care, senior managers, counsellors, providers? How do adult social care colleagues perceive the NHS? Are there behaviours linked to these perceptions that we might want to change? Quite loaded questions there in some ways, or is it all a family in your patch, where the person's at the centre and the organisations make it work? A bit like Neil said, you don't need to see the wiring or the recipe. You just need to see the you know, the proof in the pudding, if you like. And the last one, how can the adult social care and health sectors work together to better achieve each other's priorities? So anyone want to come in? Somebody's put the questions in the chat as well. Don't be shy. 52 of us. 49, 3 have legged it off. Simon, thank you for breaking the tension.
That's okay. Good morning. It's great to be here, and it's been just so good to have the time out to listen to these presentations and discussions. And I think I'm looking broadly at these questions. In where I work, we've got social workers and health workers in one NHS trust, and I actually think whilst there've been a lot of benefits to that we've seen, I think it's a constant question to ask. But how well are we working together, and what's that experience like for people who receive the service? Are we narrowing down the number of times we ask them the same questions, and are we better able to exchange information across the system about people that serves them in a much more cohesive way? So I'm not saying we've got there. I'm saying that it's an important prompt to keep asking that question about what makes that happen in your area. And it's not just all about people being in the same place.
Thanks, Simon. That's a really good reflection, I think. Can you just remind colleagues of your patch if people don't know?
Yeah, it's Wirral Stewart.
Yeah. I think Jackie's put something in the chat. Well, you had your hand up as well. Did you want to come in and say anything, Jackie?
Yeah, it was just to expand on that, really. I think that in terms of that health and, health and social care, working more, working more on the front line and on the ground level, I think there's still that slight rub and disconnect and discourse between health and social care. It's very much based, personal relationships. You can build personal relationships, and we did very much do that when I worked in a specialist LD team where we co-located, and those relationships very much built up, and the outcomes, there's never been a lot of research on what outcomes that I know of on outcomes for the people in terms of working in that manner. But from a practitioner point of view, what I observed was that you got more, oh, well, are you working with that person? Yes. And you shared information and shared knowledge. I think there is still very much, because health and social care are not on a parity in lots of ways, that element of the sort of territorial boundary where you're trying to hold your boundaries and hold your line. But also, I think sometimes, particularly within health settings where social workers have come into health settings, hospital settings being more of the acute level, then there's been a sense of assimilation rather than working together, and there's been a sense of not having that, mutual respect for each profession. So I think that that's just, I think that is something that, with a change of narrative and a change of working, will needs to improve, and we need to be part of that as well. But I think overall relationships are really important, and those key relationships, and I've got a lot of really positive, good relationships with many organisations, including health.
Thanks, Jackie, for those reflections. Just again, where are you coming in from? Just for
Warrington.
Warrington. Thanks, Jackie. And you made me think again. It's not a Wigan day today, but going over to Alaska for a minute. I think it was an area called Newer where they kind of a bit left to it in the American system, and had done some like really important work, I think, about just getting past all the process differences and all, maybe even the kind of pay and rations differences, and making sure social care and health teams were integrated at the front line. And once people get to know each other and share the milk in the fridge and aren't labeling it the health milk and the care milk, I think you're somewhere. And it was kind of optimally being if you're 15 feet away and talking about the same people with a kind of person-centered mindset and an idea of a different conversation, including the social aspects, you might actually get somewhere together on a new model of care and health that's designed around people. And it's definitely at our best in Wigan, I think, when we've been closest to realising what we've been trying to do under the Wigan deal. But we're by no means the finished article, and there's some things the pandemic's got in the way of that I think we'd like to get back to in terms of face-to-face staff co-locating in neighbourhoods in the place. So Adrian, thank you. I can see you've got your hand up. Do you want to come in, say where you're from, and any reflections?
Yeah, sure. I'm from the Innovation Agency, which is the Academic Health Science Network for the Northwest Coast, which is a bit of a mouthful, I know. But I just wanted to reflect on this issue around the relationship between health and care, because prior to this role, I spent 15 years in local authority working in adult social care, and now I'm in the NHS. What I found, and what's really surprised me, which I wasn't expecting, was some of the quite widespread lack of understanding around what social care actually is and does, and the preconceptions around it. And I think unless some of that can be addressed within health, and to actually appreciate fully the value of care and how it can contribute towards people's well-being and reduce or improve health outcomes, and some of this I put in the chat about this should be considered as part of the development of, integrated care systems and place and primary care networks. But it's just, I suppose, just wanted to reflect this complete surprise that I had after being in social care for such long. I thought everybody knew. I thought everybody in health understood the scope and the range and the expertise in social care, but it isn't quite there. That's just all I wanted to say.
Yeah, you're giving me flashbacks, Adrian, actually, to Greater Manchester Life in 2015 when we'd done the devolution kind of deal at that time, pre the ICSs coming through, on GM having a different kind of, overall approach. And I think we were asked the size of the NHS workforce and the size of the social care workforce, and we ended up saying it was 56,000 NHS workers and 7,000 social care workers, and all we'd done is counted social workers, and rather than the absolute extended delivery of social care, which is at least as large, but that sense of kind of not just volume but kind of range of things that social care does, even within our own system. When we were being thoughtful about these things, there was a big kind of understanding gap to bridge, which I'm sure we still need to work at in all places. So definitely what you said kind of resonated with me, and some memories of not too long ago running into similar things.
Well, my aim is to try and subvert from the inside.
Well done, Agent Quinn. Yeah, brilliant.
The social care flag.
Thanks for the contribution. I can see the questions. I can't see any other hands up. I think they pop up if on my screen if somebody puts that up on the yellow hand bit on Zoom. Does anybody else want to come in with a thought on any of those three questions, or any other thoughts? If I've missed anything in the chat. Ruth identifying with Adrian's. Oh, right, I've got two now. I've got Ruth and then Kath. Ruth, do you want to come in?
Yeah, I just wanted to say I work around engagement and patient voice, and I've worked in the health service and I've worked in a number of different settings. And I just think there is a real, and I think that's why I thought the model around social care that was described in the first two presentations was really important. And I do think there is a real difference between the narrative around kind of person-centered work in social care and in health. And I do think that creates real difficulties in terms of, managing the differences. I think it's almost inevitable in health, I have to say, because I just think it's almost built in to be quite paternalistic. It does need to be overcome. I'm not saying it doesn't need to change, but I just think that is a real clash, I think, between the two sectors. And I'd be interested in other people's views on that.
Thanks, Ruth. Definitely agree. It's an inherent tension. If people can put things in the chat, I think I'm going to take Kath's question. If you can put stuff in the chat, and I'm going to try and get us into the concluding Slido after Kath's come in. Hi, Kath. Good to see you. Do you want to come in?
Hiya, Stuart. Yeah. Am I off mute?
Sorry, you are. Yeah, we can hear you.
Yeah. I was going to say, I was just looking at the questions in terms of, how are we perceived, and, how could we work better? And I think one of the big areas where there's a lack of understanding is the level of work that adult social care do with private providers and independent providers. And sometimes there's a frustration, isn't there, that we can't just tell care homes or domiciliary care agencies or whatever because of some of the capacity issues that we've got. And so I just think that's a particular area where we need to do more work in terms of, because it's a really complex environment that we operate in, isn't it? And I don't think there's still, even at a senior level, an appreciation of the nuances of that and managing the relationships with our providers. So I think that's an area. But the other thing that I did just want to say as well, which I'd put in the chat earlier on, I was completely inspired by the first two presentations and the need to shift our narrative from one of problems to one of hope, and and really shifting that and attaching that to the stories. And I'd put in the chat earlier on, I think some of the work it's how can we as the Northwest maybe try and pull together, because it takes a lot of time and effort to do it individually, doesn't it, and skill to really form that narrative. And we're all struggling to manage the day-to-day operational demands. So I was just asking really whether we could harness some of the wonderful stuff that's been shared this morning and that approach to try and pull together a sort of some baseline slides around the narrative, something like that, that we could then take away to our places and then adapt. Because a lot of it is it's a real skill shifting that narrative, and one that we don't all necessarily have. But if we're just pointed in the right direction with some basic support around that, I think we could deliver that. We could all deliver that and shape that at a place level.
Quite agree, Kath. I noticed your comment, and my one about us having a chance to put the heart and soul in our Care 2030 narrative was along the same lines, really. I'm not sure we'll have perhaps the skill and the flourish that Madeline's got, say, in our authorship, but we can have a go, can't we, at kind of something that really speaks to the passion why people come into the sector in the first place, and getting that across for all 23 constituent ADAS members. Definitely an action point. Thanks, everyone. Sorry to sort of do this in a big kind of group rather than the original methodology, but just trying to get us to the last opportunity to revisit our, hopefully, the TECL work on the Slido opportunity to just bang a word cloud back up again in terms of what we've heard this morning. And I think I've also got to, probably I'll do it now, we've got to do a plug for the next event, which is the 7th of July, I think. So if you like this one, look out for masterclasses. I think the next one might be health inequalities, but someone can put it in the chat if I've got it wrong. But please plug it to other people, in your teams if you've got some value from today, and look out for the events. And Helen, can I pass back to you to administer this bit?
You can, and I'm hoping, it's an easy job, hopefully now. So we've got the QR code if people want to go in through the QR code. And obviously you've got the number there if you join in on your browser, which is 507025. And the question is, what does adult social care mean to you now, maybe, after all our discussions that we've had? Responsive, lifeline of support, enablement, empowerment, life, humanity, life. It's coming out very strongly, empowerment. Life, love, family, health. I like that one. A solution. Care, life and care, and empowerment. I think we're on 18, so we've still got, you know, I think we've still got about 44 people on the call, so we'll just hang in a bit longer. Dignity, hope.
Neil put an interesting thing in the chat about independence earlier. I know it was kind of a feature of a lot of the vernacular, then it becoming a sort of, you know, a cuts agenda that isn't quite. I like to tease our strategic accountant for adult social care. Some people will know Leon Bergman, and when we do stuff like this, you know, the kind of point is that care is something you need in some way in your life every day to survive. And he gets all stressed out that suddenly the social workers won't have any discipline at all about the construct of support plans or the solution that's just enough care in the community. And it's a really interesting balance to strike, I think, because that sense that actually this is all about people living the best lives, and sometimes that's ongoing support, and episodic support is really useful, and both the NHS and care do it, but people have 168 hours in the week, don't they, and need to get along and get by and be happy. So that sense of these services are incredibly important when you need them, but we all need family, we all need care, we all need friends, we all need a place to live and prospects and things to do. So I think the connection between home and care doesn't need probably over-egging beyond the connections between the original word cloud and this one, and the obvious sense of that. Please, I think we've put a link in the chat. We have it midday. Thanks for sticking with us, so many of you. Thanks again to all the people who did an input today. Massive thank you to, there's a big team behind organising this. I know we've had a few tech wobbles along the way, so well done. There's a little WhatsApp going in the background where people are panicking saying, I've only just found it actually. I think I've been a member of the group for weeks, but I've stumbled across it during the meeting. So again, a big thank you to everybody involved in supporting the session. Hopefully you've enjoyed it. Please let us know how we can improve them. Please join the next one, as you can see there, and have a great Thursday afternoon, because I think that's where we are. Thanks everyone.